So it is my real pleasure to introduce to you Dr. Harold Kalant.
Thank you very much, Nadi, for that very generous introduction. I have to apologize to you for standing beside the lectern rather than behind it, because I have to be able to see this screen down here, and with age I've grown shorter. Also, you'll notice I'm standing to the left of the lectern rather than to the right. That will offset some of what I have to say, which is seen by some people as being to the right of center. The topic of cannabis is unusual in the sense that at the same meeting and among the same group, we have to talk both about its medical use and about its non-medical use and the problems that both generate. And I'll start with the medical aspect. As I'm sure all of you know, there's a very, very long history of use of cannabis in folk medicine, very well described, perhaps best described in India in the second half of the 19th century. But it was a basic part of Indian folk medicine for long before that, and it was used for an astonishing variety of symptoms: pain, fever, vomiting, diarrhea, insomnia, cough, epileptic seizures, muscle spasticity, and so on and on. And its non-medical use was quite unlike the non-medical use in North America. It was limited to family ceremonies on religious occasions a few times a year. But it later passed into Occidental medicine from India, and it was used for a similarly wide range of indications. I would invite you to look at the picture of the cough syrup, which was from the United States in the late 19th century. And if you can read it from where you're sitting, you'll see that it contained, in addition to cannabis indica, it contained alcohol, chloroform, and morphine sulfate. I'm sure it was a very, very effective cough remedy. But gradually it fell out of use. I mean, cannabis fell out of use as modern synthetic drugs of much better shelf life, exact composition, and much more convenient control of dosage came onto the market. And by the time cannabis was outlawed in most countries between the 1920s and the 1940s, incidentally, Canada was one of the earliest in 1923 for purely political and racial reasons rather than scientific or medical reasons. But there was not much objection to the outlawing because it had largely gone out of use by then in any case. However, when interest in medical applications was renewed after the appearance of widespread non-medical use in North America and elsewhere in the world from the early 1970s on, a similarly wide range of applications has been either used or claimed or advocated. At present, in Canada and in a number of other countries, cannabis is approved for the relief of neuropathic pain, for nausea and vomiting due to chemotherapy, for stimulation of appetite in cachectic patients. It's not terribly good for that because it stimulates the intake of carbohydrate rather than of proteins. So for tissue replacement, it's not very good, but it certainly does increase caloric intake. There is some clinical evidence, some of it rather good actually, well-controlled trials, but not enough replications to obtain approval so far. But epilepsy, and we're talking here principally about CBD, not THC, multiple sclerosis for spasticity and bladder control, Crohn's disease, various sleep disorders, antipsychotic action, again a rather good clinical study, neuroprotection. But there are also claims for which the evidence does not back it up or for which practical clinical considerations do not justify its use. Here are a couple of examples. acutely, THC produces some bronchodilation, and the idea was proposed that it could be useful in the treatment of asthma. Oral cannabinoids have not been tested for this purpose, and smoked cannabis was not useful because the dilation effect was offset by bronchial irritation and therefore bronchoconstriction due to the smoke constituents. Another instance, glaucoma. THC does decrease intraocular pressure, but the effect of a tolerable dose, small enough to not produce unwanted psychoactivity or other side effects, lasts only for about 4 hours or so. And in order to prevent damage to the retina and the retinal nerve, or the optic nerve, you have to control the intraocular pressure 24 hours a day. And that would mean that you'd have to smoke cannabis or take it in some form around the clock every 4 hours or so. Obviously not a very practical treatment. Now, the effects underlying non-medical use are not as wide, but they still have some overlap with the effects that constitute the basis of medical use. A mild euphoria, which is the basis also for some of the claimed antidepressant action, which is not proven. Sharpened sensory perception or greater enjoyment of sensory stimuli. Sedative effects, relaxation, reduced anxiety, but only at low to moderate doses. High doses provoke anxiety, so it is not an accepted treatment for anxiety in conventional medical use. And greater sociability. The possible explanations for such a wide range of actions are several. The first is that cannabis, crude cannabis, is a plant material, and like any biological material, it has more than hundreds, it has thousands of constituents. And there is a wide range of the constituents in cannabis, of which some may have useful therapeutic applications. Not only the delta-9 THC and CBD, but other cannabinoids such as cannabigerol, terpenoids, and other compounds which are not yet, well, are still under continuing investigation. Another factor is that there are multiple receptors and effector systems on which the cannabinoids act that are widely distributed. The THC acts on CB1 and CB2 receptors, which are part of the endocannabinoid system, and I'll come back to that in just a moment. CBD competitively blocks the binding of THC to CB1, but it is an agonist at a different kind of receptor, a G-protein linked receptor called GPR55, which is present in the inflammatory systems and pain pathways. So that here there are multiple ways in which these substances can act. And another thing is that these receptors and effectors are extremely widely distributed in many tissues and organs. I would say the majority of tissues and organs throughout the body. The CB1 receptors are mainly on axon terminals of the conventional neurotransmitter types in the central nervous system, also present outside the central nervous system in spleen, eye, GI tract, the testis. CB1 similarly on immune cells, blood vessels, liver, kidney, bone cells, peripheral sensory neurons, and in the brain in microglia. And the GPR55 are found in the brain, in the adrenal glands, in the GI tract, in the spleen. And CBD, in addition to the GPR55, and some of the other endocannabinoids also bind to vanilloid receptors and other types in peripheral and central pain pathways. So that there are a number of things that contribute to this extremely broad range of actions. The endocannabinoid system that I mentioned a moment ago, apart from the receptors, consists of the synthesizing enzymes that produce the endocannabinoids from cell membrane lipids. There are the degrading enzymes that break them down very rapidly after they've acted. And there are specific transporters that carry the free endocannabinoids that have been released presynaptically into both the postsynaptic and the presynaptic terminals where they are degraded. And this graph I would just call your attention to I'm sorry I don't have a pointer to illustrate it, but you'll see the presynaptic axon terminal above with synaptic vesicles containing the conventional transmitter, whatever it happens to be in that particular type. When a nerve impulse arrives at the terminal and causes release of the transmitter binding to its postsynaptic receptors activates the synthesizing enzymes to produce the endocannabinoid, which is rapidly released, diffuses backwards across the synaptic cleft, and attaches to CB1 receptors on the presynaptic terminal and alters the membrane properties to change the electrolyte content of the cell in such a way as to stop the continued release of neurotransmitter. In other words, it plays an important role in normal transmitter function. The endocannabinoids are released only on demand, that is, when this axon terminal is activated by an impulse. The action of the endocannabinoids is rapid to stop further release of neurotransmitter, and then itself is rapidly broken down so that the whole thing functions as a rapid transitory modulator of synaptic transmission to keep it within the normal limits, and in that way plays a fundamental role in normal nervous system function. But on the right, well, my right, yes, it's your right as well. The graph, the second section, part B of that picture shows that that no longer applies if you expose the synapse chronically to a high concentration of either endocannabinoids or even more so of the exogenous, the plant cannabinoids, which bind more firmly to the receptors and keep and their action is very long. And with chronic stimulation, an adaptive change occurs that the receptors are desensitized and internalized into the axon terminal, and therefore the cannabinoid gradually loses its effect. So that if you increase the dose, the therapeutic effect that you're after, instead of getting stronger, gets weaker as you raise the dose beyond the one which gives you the maximum useful effect. And therefore, sustained high concentrations are not useful therapeutically. And that means that for cannabis, as well as for the endocannabinoids, only small or moderate doses are therapeutically useful, and high concentrations lose much of their therapeutic value. And if a patient insists that he or she really needs a more potent preparation and a larger amount, you have good reason to suspect that the reason the patient is asking for that is for non-medical rather than medical reasons. And that's been backed up by studies in many countries now to show that among people who use cannabis and say that they are doing so for medical purposes, the great majority of them, and those who do not have, in fact, a medical recommendation to use it, are former non-medical users who now find that it's more convenient to say that their use is medical. And that's something that one reason why many physicians have been hesitant to prescribe. In Canada, you have to virtually prescribe it. You have to write a letter saying that it is that this patient may well benefit from it. And many physicians are unwilling to do that because of the fact that they are suspicious that they are going to be exploited by people who simply want cannabis for non-medical use. I don't know what the answer to that is, but it is certainly a real problem. This illustrates the reversal of effect if you raise the dose too high. This is the use of CBD in the prevention of nervous system damage, in other words, a neuroprotective effect against the effects of hypoxia, hyperthermia, toxemia, etc., cranial mechanical damage, and so on. The left-hand bar, the white bar, is simply the control. That's the size of a cerebral infarct after the imposition of a standardized injury in an experimental model. The next column to it is a very small, a tiny dose of CBD, which is too low to have any effect, and therefore the size of the infarct is the same. But the next one shows a medium-sized dose, which does produce a very substantial decrease in the size of the infarct, a maximum decrease, but as you raise the concentrations higher and higher, you get less and less beneficial effect. And the same reversibility of action and loss of therapeutic effect has been shown in the case of learning and memory, in the case of stimulation of neural stem cells and migration to their final site of fitting into the circuits that they're meant to belong to, and the endocannabinoids at their normal low concentration play an important role in this process, but exogenous cannabinoids in substantially higher doses markedly impair it. This is an example from what is known as the Dunedin study. It was an amazingly good study carried out in New Zealand, in the city of Dunedin. A birth cohort of over 1,400 children born in that city in the same year was examined. The great majority of them stayed with it. This is an unusually good, large, prospective cohort study. They stayed with the study from the time of birth until now. Most of them are in their mid to late 30s. And they were re-examined every 3 years during childhood, adolescence, and then at 5-year intervals during adult years. And the examinations consisted of history, physical exam, psychiatric, psychological exam, tests of various kinds, including intelligence tests, and a whole range of questionings about social adaptation, employment, school record, and so on. At the left-hand side of the graph, this graph shows the findings on intelligence tests at the age of 35 to 39 years compared to the IQ in the same individuals at the age of 12 before they began any use of cannabis. The horizontal line across the middle is the starting point, the 12-year point. And the bars show difference from the 12-year intelligence test when it was measured again at 35 to 39 years of age. Those who did not take up cannabis use are not shown in this graph. Their IQ as an adult was in general slightly higher than it had been at age 12, which can be attributed to normal maturation, experience, learning, and growing up. But these are the results with those who did initiate cannabis use. The small bars, the gray bars in the right of each pair, are from those who did not initiate cannabis use until they were almost reaching adult age. And their difference from their 12-year age IQ is not significant. But the black bars are from those who began use at 12, 13 years of age and continued to use throughout adolescence and early adult years. And you can see that there was a significant drop in IQ in their late adult years compared to their 12-year test results, which was greater the more intensively they used cannabis. The left-hand one was those who used cannabis heavily enough to have at least one diagnosis of cannabis dependence during their adolescent years. The second one shows those who had 2 diagnoses of dependence during their adolescent years. And the third one shows the results in those who had 3 or more diagnoses of dependence in their adolescent years. And those changes are not reversible. Even if they stopped later, they missed the maturation process that should have gone on during their adolescent years and their early adult years, and therefore there's nothing that can turn those results back. Now, what about dosage considerations? I've talked about moderate doses and large doses, etc. Well, most clinical studies that have been conducted well with good control of dosage and with frequent observation and determination that there was or was not a clinical effect, etc. Most clinical studies with cannabis have used not more than 1 to 4 grams a day of a preparation with about 10% THC and at least 1 to 2% CBD for maximum benefit with the least adverse effect. Unfortunately, when Health Canada was forced by the courts to initiate a medical marijuana program, they had to license producers, a substantial number. There are over 30 licensed producers in Canada now, but they did not set any limits to what the contents of THC and CBD in those products should be. And the result is that there is a tremendous variety of products available legally for medical use. Some of them are much more potent than 10% and with almost no CBD. Here are a couple, for example, with less than 1% CBD and 22 or 23% of THC, and with names which are obviously meant to appeal to youth. They're not medical, these are not medical drugs. They're not, their names don't indicate that it can be used for treatment of certain diseases. They're staking a claim to a share of the youth market if legalization of non-medical use goes through, as the present government intends to do. Now, medical use and non-medical use are normally under separate regulation, under separate legal controls. For example, cocaine and heroin still have small but legal use in medicine in many countries. For example, cocaine is used in some nasal surgery because it has a good vasoconstrictor effect. But nobody argues that therefore they should be legal for non-medical use by anybody who wants to use them. Yet for cannabis, medical use is frequently given as an argument for legalization. And the question is whether this is simply illogical thinking or cynicism. Certainly, the medical applications have been argued as a reason for backdoor entry into widespread, practically legal non-medical use. Now, the Canadian government has announced its intention to legalize cannabis this coming year, but with strict regulation to prevent access by adolescents. And that brings up the question then, what is the basis of a sound, beneficial drug policy? What do you need to enact a beneficial policy? Well, I've identified, I think, to my own satisfaction, and I hope it will be to yours, a number of things that you need. You need a clear identification of a problem to be solved or of a desirable goal to be attained. You need full, unbiased information about the benefits and the harms caused both by the drug and by each of the various policy options, because the law can also have both beneficial and harmful effects. And you have to make value judgments to select an optimum balance, which beneficial effects are more beneficial and which are less beneficial, which harmful ones are more harmful and which are less harmful, so that you can draw a sensible, rational, cost-benefit assessment that will help you decide which is the best policy option to adopt. And you should have a built-in close monitoring of the consequences of any policy that you do adopt, a mandatory review of the results at a set time, and a readiness to change policy if the results show that it's desirable to change it. For cannabis policy, then, what are the problems that we have to solve, or the desired goals to attain? First of all, the law, the present legal prohibition, has had harmful effects. There's no question about that. There are people who have been sentenced to prison and received lifelong criminal records for simple possession for personal use before the youth criminal law was changed to make that impossible. But there are many people who are stuck with such records now. One desirable benefit would be a major reduction of the black market. One desirable goal is prevention of harm by excessive use of the drug, both acutely, accidents, acute psychotic episodes, a variety of other things such as myocardial infarcts in people who smoke despite having a pre-existing coronary disease, and also chronic harms, of which you have heard a great deal during the course of this meeting. There's also a need to protect the most vulnerable users, who are youth. And another benefit in the eyes of many people to be sought is increased freedom of choice for moderate, mature users who are not going to run into any harm from it and would be free to use it without risk of legal penalty. And from the government's point of view, there is clearly a desirable goal for them, which is to get revenue from a new industry with new employment, new sales and taxes and all the rest of it. What is the state of our knowledge about the effects of cannabis, the harms or the benefits produced by cannabis? We have good data on Canadian past year users in different age groups. We know that in the general population of 15 years and up, the use is about 10%. But in adolescents and young adults, it's about 35%. And between 25 and 29 years of age, it gets closer to 40 or even 45%. We have good data on the numbers of accidents and fatalities from driving under the influence of cannabis. We have rough data on other health consequences of heavy use. We know the kinds, but we don't have, as yet, very good figures about the frequency. There are no systematic data on pleasurable or beneficial effects of moderate controlled use. Nobody has actually done a population study to try to define quantitatively how many people get harm, or rather get harmless pleasure, and how much pleasure, and under what circumstances. Dependence, on the other hand, we have fairly good figures. We know that among adults, the frequency of dependence is about 10%, compared to about 16 to 18% in adolescents. What is the state of knowledge about the effects of legal prohibition other than the criminal records that I referred to, the 600,000 Canadians who are stuck with records from the past? What do we know about what the law does as it's applied now? Actually, there is very incomplete knowledge about the current outcome of arrests for possession alone. And I have to stress, possession of small amounts for personal use alone. I'm not talking about criminal charges or records for trafficking, for importing, exporting, for driving under the influence, for violence, or whatever. Only for possession for personal use alone. The claim is made that there are thousands and thousands of people who are subject to such punishment every year, but the fact is we do not know, because Health Canada doesn't give regular data, or hasn't until very recently, for the outcome of charges or of arrests that are made. It apparently, as far as beneficial effect is concerned, the claim that prohibition does not work is simply not true literally. It does work, not as well as society would hope that it could, but apparently it does deter many people from use. because a use in the general population of 10% for an illegal drug is a lot less than use of 75% of the legal drug, alcohol. So I don't see how one has any basis for denying that it does have some deterrent effect. And there are surveys which have shown that among people who do not use now, a certain significant percentage would intend to use if it is legalized. But the real problem is the inconsistent application of the law in different parts of Canada. In Canada, the criminal law is passed by the federal parliament, but it's enforced by the provincial parliaments, and they differ quite markedly in their political stance to right or left, to severity or lack of severity in application of the cannabis law. And I would like to bring to your attention a study which took place in British Columbia in the years 2010, 11, and 12 by Plecas et al. They had access, with the cooperation of the Royal Canadian Mounted Police, they had access to all of the records for every police-reported detention incident in British Columbia in each of those years. And the figures are about the same for each of the 3 years. These are the figures for 2012, but they're just about the same as in 2011 and 2010. About 22,500 detentions for cannabis possession alone. Well, no, I take that back, for cannabis possession. Nearly 14,000 were released with just a warning or in some cases a referral to treatment, and over 4,000 were dropped for lack of evidence, so that it's clear that the great majority of those 22,000 detentions did not result in any court action or any records of any kind. 4,257 charges were laid, but in 4,000 of those, possession for personal use was only a minor add-on to charges for more serious crimes, because the police often make a practice of adding on extra charges so that the punishment can be increased if you're convicted. But the 4,000 were, the charge was not for possession alone. Only 249 were charged only for possession. Half of those, the charge was dismissed, and only 42 were convicted, of whom only 7 received a short jail sentence, not prison term, but 5 to 10 days in jail. And these were all repeat offenders with long criminal records for other events. So in British Columbia, one would have to say that the harm inflicted by the law is very, very small. Yet we know that in other provinces it is substantially larger, and the problem remains how to bring about greater uniformity. But what do we know about other options? Decriminalization of possession has been brought into effect in Australia and Portugal and a number of US states, and it was found not to increase the use or to increase the adverse effects from cannabis. The poorly controlled medical marijuana laws that were brought into in effect in a number of American states, starting with California, amounted to quasi-legalization, and that was followed by increases in use, in adolescent use, in driving under the influence accidents, and in trafficking in neighboring states where it was not yet legal for medical purposes. Full legalization has been enacted so far in Colorado and in Washington. It's been enacted in Uruguay, but it didn't come into effect until this year, so there are no data available as to what its effects have been. But in Colorado and in Washington so far, it has been followed by substantial increases in use in all age groups, by increases in emergency visits, driving under the influence accidents, fatalities, diversion to juveniles who could not legally get it, and so far no apparent reduction in the black market. This illustrates the traffic deaths, and I would call your attention to the three different slopes in the first, the middle, and the right-hand part. The first slope was after the enactment of the medical marijuana laws in Colorado, but before it became widely commercialized. The second slope, steeper, of increase in deaths, traffic deaths from marijuana, was after extensive commercialization. And the final one, which is still steeper, was after legalization. Same thing, what do we know about the prevention of use by adolescents? First of all, in Canada, the Canadian Centre on Substance Abuse has done a study of school-based education programs and found that they were not very effective in changing the adolescents' knowledge or acceptance of knowledge about adverse effects of cannabis. And they had only a minor effect on by delaying somewhat the onset of use. Alcohol prevention, again, regulation has had very poor effect, very low efficacy in preventing access by youth, because the high school surveys done every 2 years by the former Addiction Research Foundation and now continued by the Center for Addiction and Mental Health, the most recent figures available show that at the age of 12, there were already something like 5 to 10% of kids using alcohol. By the age of 17, at grade 12, 74% were users, 20% had been drunk in the past month due to binge drinking. And legalization in Colorado has been followed by an increase in youth use, even though it's not legally permitted, more steeply, as I just showed you, than the national average, much more steeply than the national average. This is past month use in adolescents aged 12 to 17 in the United States. The blue is states which do not have medical marijuana laws. The red is those which have medical marijuana laws, and the green are those like California and Washington that have both medical and non-medical legalization. Now, to prove that that is a causal effect is going to take more time yet. We need to see what happens, whether this continues as a trend of increasing use over following years. But it is certainly a serious warning that we have to look at this. We've got to know what does happen. The same thing, past 30-day use, and this is past month use in college-age students, and you see the same thing. This is the source of the marijuana that high school students got in Colorado after legalization. At the left, 1% were able to buy it from legal vendors, even though they were not supposed to be able to. Slightly more were able to buy it from the middle one, the 6% shows dispensaries, which were not particularly, not very careful in monitoring the age. 22% got it from their parents who were themselves users and then got it legally and then gave it to their children. And the right-hand bar is those who got it from their older friends who were old enough to buy it legally and bought it for them. So what are the conclusions we can come to? Are we okay on? Yeah. Yeah. Decriminalization does prevent the major harms of prohibition without increasing problems caused by cannabis use. Legalization also prevents harms caused by prohibition, but it appears, we can't yet say with certainty, but it certainly appears to introduce more harm caused by cannabis use, and we need to know whether this apparent increase is a true bill, how great it will be, and how long it will last. We do not yet know how to prevent use by adolescents or heavy use by adults, even though that is one of the intended safeguards that regulation is meant to produce. And you have to ask yourself, which policy is overall the best for society at present? My view, and I certainly don't pretend that I'm going to speak for all of you, but my view is that the best would be to decriminalize now, to legislate a pardon for the 600,000 people who are stuck with criminal records just for possession of personal use from many years ago, and to institute careful monitoring of what is happening in those places that have already enacted legalization, so that we can learn what are accurately learn what are the results of legalization with respect to use and heavy use, and implement at once intensive research on better methods of changing the attitudes of adolescents towards cannabis as they change themselves with respect to tobacco, but as they failed to do with respect to alcohol. So that after 5 years or so, we are in a better position with respect to what we know about each of the various points involved, and one hopes also in a better position to prevent use by adolescents, and at that stage to make a better informed decision about whether or not to proceed with legalization. I would add that legalization is in many respects an ideal for a democratic society, provided it does not harm the general good. So I personally do not rule out the fact that legalization may someday be applicable in our society without harm. But the question is, we have to know. And with that, I hope that it will stimulate you to do your own assessment and your own value judgments. And I would just point out that a detailed debate on decriminalization versus legalization was published in the International Journal of Drug Policy in August of this year. Colleagues and friends of mine who favor legalization now with strict controls make up 2 of the 4 articles, and I'm the lone voice on the other 2, but it has the form of a formal debate. A statement for, a statement against, a rebuttal by each side. And I hope that if you are interested, that you have access to it and that it is of some help to you in making your own judgments. Thank you.